from the waiting room? I see some sitting there.
Yes, I'm sorry. I didn't realize I was muted.
Okay. Something in the chat. Okay, that's you. All right. I have exactly 6 o'clock right now, so we can give it just another minute to make sure everyone has a chance to join, if you guys are okay with that.
Got it.
Okay. Give it another minute.
Shout out to Dr. Fernandez.
Okay. All right, Dr. Baca, would you like to begin?
This program will be recorded. We expect that probably more people will be watching it remotely. So I have the distinct pleasure today to introduce Toni Large. Now, we are in the process of having our program for transparency in drug pricing. So this is our second of the series. And what Toni's going to talk about today is basically PBM reform. On the first video, if you haven't seen it, please go back to it at some point with Dr. Levin. But the PBMs are the middlemen that basically are one of the large driving these things apparent to our local politicians. And she also works for the College of Rheumatology, the FSR, the Florida Society of Emergency Physicians Orthopedics, and basically is here to discuss what's happened in the legislature to reform PBMs. As you know, PBMs are gobbling up a lot of dollars, including state dollars, that go into plans such as government commercial insurances, as well as Florida government, Medicaid. So if we can get this under control, then it's going to save our citizens of Florida lots of money too. And besides help our patients. So thank you, Toni.
Oh, my pleasure. Thanks for having me. Yeah, and right off the front, slide here, we're talking about PBM reform. And really, when you talk about healthcare, a lot of it is the funding that goes along with healthcare and how patients are getting their premium dollars used to make sure they're accessing the care that they need to keep them healthy. So we're going to look at the hidden middleman, as we all call it, the PBM, and how they're gobbling up the healthcare dollar and how in many cases it's for profit versus benefit for our patients. Let's see here. Let me make sure I can advance the next slide. First, I want to start out, like we said, they are the secret hidden middleman. They currently are legally able to pocket much of the healthcare dollar. And this presentation is going to look at solutions of what the Florida legislature could enact to help ensure that more of those dollars are going to actual patient care or even prescription drugs or even procedures that they need. So looking at some of those solutions, I first wanted to also talk about some of the successes we've had recently, and then some of what I'm going to call glitches that probably still need to be fixed. And then some are also policy issues that haven't been tackled over the last several years, despite the fact that there's been legislation filed, but no bills have been enacted. Some of the tide's changing, and that's a good thing. So we'll also kind of go over some of the political landscape as well. So some of the successes we've had is back in 2021, Dr. Mazzullo, Representative Mazzullo, did add some language into statute that would say if your patient was on a health plan, they switched to a new health plan, then their drug, if it was being paid for by the insurer the previous 90 days under the old plan, the new plan would have to cover that. That's a big deal, especially for patients who are on drugs that make them medically stable. We'd want them to be able to continue that drug therapy without having to jump through all the prior authorizations and step therapies and really just start the process over. So that was taken care of in 1991. And then we look at last session in 2022, step therapy. We've been working on this for a really long time. And it's amazing how long it's taken to get some of these kind of simple things that we think should have been in statute all along, but now they're there and we hope they're good patient protection issues. The bill first actually defines step therapy protocol, and ironically that had never been in statute. It also says that there has to be a process to receive a protocol exemption. Thirdly, it also says that the HMO has to publish on its website and also provide to the insured in writing a process by which the patient and the healthcare provider can request a protocol exemption. That procedure must include, and these are all really important things, the manner in which the patient or the healthcare provider may request a protocol exemption, also the time frame in which the health insurer or HMO is required to authorize or deny a protocol exemption request. How many times have you put in that step therapy request or that prior auth and it just sits there and you and your patient wait and wait and wait, and what that means is your patient's health is usually deteriorating during that time. So now they have to be transparent on timeframes in which they're going to act. They also have to tell the timeframes in which an appeal has to take place if a patient is denied a request. And then I would say also, I underlined the last bullet where I wanted everybody to understand this doesn't just deal with prescription drugs. It also covers medical procedures and courses of treatment. So that's really important. So this isn't just about prescriptions, but all those other things that we need prior authorization for. Now the insurer, when they deny a protocol exemption, they must provide a written explanation of the denial, including the clinical rationale supporting the denial. This is a really huge deal too, right? Because sometimes you get the denial, but they don't exactly say why they were denying it. And that means then you can't go back and fix or provide additional information to, have them reconsider. So this says, no, they have to give that to you in writing. And also, like I said above, a procedure for appealing that. I will say this did go into effect July 1. In the next slide, you'll see I kind of say, is there some glitches though? And I will say one of the problems when I talk to the Office of Insurance Regulation that oversees insurance companies, I say, okay, Department of Insurance Regulation, how have you required health insurers to come into compliance with this? And they don't necessarily have an answer. So that makes me really worried. And one thing they say, well, if a physician or a patient feels like they don't have access to this information and it's not published as required on the statute, then they'll have to go to Jimmy Petronis' office. Of course, he's the chief financial officer. In his office, he has the Division of Consumer Services. Most people don't know this, but the Division of Consumer Services allows both a physician and a patient to file a complaint against a health insurer. So I'm going to put it back in your hands, doctors, on this call. If you see that the requirements that I just outlined in House Bill 459 that did pass and become law are not available to you or your patients, it's time to take action. You can use this slide. It has both the email that you can send a complaint to. It also has the 1-800 number you can send a complaint to. It has the website that you can link on the online link there. And it also tells you a little bit more about who all can file the complaint and also what all is needed. Really important. It tells you exactly what you have to lay out in the complaint. It also is, there's a time frame for the Division of Consumer Services to take action on these complaints. So you'll see there's about a 20 to 30 day turnaround. And in most cases, they say on their website anyway, that they actually want these complaints to be resolved within 30 days. Of course, that's outside of some of the obstacles that are in the way where you have to go through an internal dispute resolution and an external sometimes. But this is a good resource. And also, when I go to the legislature and ask for action and say there's this problem, many times they come back to me and say, wow, that's funny because we don't have a single complaint at the consumer hotline about this. And I say, oh, yes, they're there. So we really need to utilize this consumer hotline and have both physicians and patients lodge complaints when the insurer isn't meeting these requirements that are now part of the state law. So moving ahead a little more, I'll say in June, we saw the Federal Trade Commission. They voted unanimously to put pharmacy benefit managers and drug makers on notice about a new enforcement policy against illegal bribes and rebate schemes that can block patient access to competing lower drug costs. This was a huge announcement by the FTC. We're looking to see how the investigation moves forward. They did actually even name specific companies that they really were looking into: CVS Caremark, Express Scripts, Optum, Humana, Prime Therapeutics. I can go on, but that list is probably some of the players that you know of that really put up barriers to access for your patients. So we'll keep you posted as we follow this and see what the FTC is going to do. There was a comment period on this, and I know a lot of the groups did provide comments to the FTC, and that's what they used in determining whether or not a further investigation needed to take place. So that's kind of what's happening right now on the federal level as far as investigation into PBMs. And I left the article there on the left-hand side so you can kind of see and read a little bit more about what kind of was the impetus to that, and also what they're going to be looking at in the coming months. And then on the state level, the governor, of course, also took action this summer. It was in July. He actually released an executive order, and he hopes that it will drive transparency in prescription costs for Floridians. Some of it has to do with the Canadian drug importation program that hasn't had as much success as some folks had thought it would when first enacted. But the second part is also looking at any of our government payers and looking at transparency that he feels is a necessity. And you can see in the bullets on the right-hand side, I put a little bit more information about what the executive order calls for. One of the many things is it prohibits spread pricing for all PBMs, and spread pricing is, the amount that the drug actually costs versus the amount that they reimburse, say, the pharmacist. It's also going to prohibit reimbursement clawbacks from PBMs, i.e. you think you're going to get reimbursed one amount for a drug, usually the pharmacy, but it's actually a much lower cost and sometimes even less than what they paid for the drug. It also directs agencies to include data transparency and reporting requirements, including a review of all rebates, payments, and other, relationships between pharmacy, insurers, and manufacturers. This is a big deal, and I will say this, in many cases, we see that these PBMs are very smart, and they change the names of what they're calling the different sums of money that they retain for profit. So I think if there's legislation that follows, there'll probably also need to be a need to define some of these terms to make sure that the PBM and the insurers are really calling them the same thing that we think in layman's terms those dollars are and where they're being distributed. And the last one, it directs all impacted agencies to amend contracts to the extent feasible with these same provisions. I think, as I understand, the Agency for Healthcare Administration is taking the lead on this executive order, but it'll affect many different groups, whether it's a state group health insurance, Florida Medicaid, which we have already seen some studies out of Medicaid showing that there is a ton of steering, and steering is another PBM word, in which they're sending all patients to one specific pharmacy, and it's not because that pharmacy is the cheapest or giving the drug at the best price. And in fact, some of the data shows that it's actually a higher profit margin for that PBM for steering those patients. And, sometimes we take for granted if we live in a big city where there's a lot of options to get a prescription filled, but especially in your rural areas, that steering can really have an impact to patients on their ability to get the drugs they need. Part of this, though, and you'll see on my next slide, I asked the question, do we need legislation this upcoming session to enact the governor's executive order? And I would say the answer to that is yes. And one of the reasons is looking at Texas. And you'll see we use Texas as a model in many of our pieces of legislation because they've done a pretty good job of PBM reform. We all have got a long way to go, but this just shows back in 2019, they passed a transparency bill in Texas. And from that, you can see this is just a little snapshot of the information that now has to be reported by PBMs. You know, the amount passed on to insurers, the amount passed on to enrollees. And look at the third column, the amount retained as revenue. Look at those dollars. And then look at the overall dollar amount there. So when asked, do we need legislation to enact the executive order of the governor? We would say, yes, we do. And in fact, we think that all commercial insurers in Florida should be having to report this information to the legislature, to the Office of Insurance Regulation. And then we can use that to quantify the need for the reforms that we want to push forward. And I'm sure if we look at the most recent data here, I just grabbed 2019 because that was the first year it was enacted and the data came in. Also passed during the 2022 session, it was a piece of legislation dealing with PBMs, but more from the pharmacy side, right? As physicians, we routinely every day have to jump through all the red tape, have to go through all the barriers that are put in place in order for our patients to get on the drugs that keep them healthy, and also the barriers just to keep them on those drugs that keep them healthy. But I want to say, just FYI, we did back in 2019 require for the first time ever PBMs to register with the state. And ironically, they only pay $50 a year to register. And prior to this legislation that passed in 2022, the Office of Insurance Regulation didn't even have much, very much enforcement mechanisms over PBMs. Another thing we did back in 2019 that was a success is we did prohibit the gag clause to be used by pharmacists via contracts by PBMs. So now pharmacists can discuss with patients what is the cheapest means to obtain a drug. And ironically, all of us with insurance, we always assume that using our health insurance benefits is going to get us the cheapest drug. But I know just from my own experience, but we also know by looking at the data that in many cases, not using our health insurance is going to get us the drug at the better cost, whether it's a discount card or using, say, more of a non-traditional pharmacy like Costco's or some of the others. You can actually sometimes get the drug at a cheaper price. And this now allows the pharmacist to discuss that with patients. But in 2022, the bill that passed now gives authority to the Office of Insurance Regulation as it relates to regulating PBMs. In addition, and I put the third bullet in red because we're going to talk about it more in the slides to come, but it also allows disputes between the pharmacist and the pharmacy audits that take place by the PBM. They can be disputed by through a third-party claims dispute process at ACA called Maximus. And also for the first time ever, there's penalties for any PBM operating in the state that hadn't registered, because previously, even though there was a requirement, there was no penalty if they didn't. And then also lastly, I point this out because once again, when we have the slides that say glitches, this is probably a glitch that needs to be fixed. The bill expressly makes a health insurer or the HMO responsible for the violations of the pharmacy audit provisions. So even, in the past, insurers have said, oh, that wasn't us. That was that third-party PBM we hired. So we're not liable for anything that took place. Well, this says no, if they're working on your behalf, then insurer, you also have the liability there. I would say this is a glitch because this shouldn't just be for pharmacy audits. It should be about any decision, step therapy, prior auth, that an insurance company contracts with a third party like a PBM to handle. They should have liability along with that contract. This is kind of, where I think we are now in Florida as it relates to physicians trying to provide care to patients. I say that every time a patient walks into your office, it's like playing Monopoly, but unfortunately, every single patient has a different set of rules that goes along with that Monopoly board. And, it's really easy to play Monopoly because we all know the rules, right? We all know don't pass go without collecting your, $200, $100. I don't know, I haven't played in a while, but we know it's set in stone, right? You know the rules, you know what's going to happen. Unfortunately, that's not the case with doctors trying to treat patients. every single insurer has different rules in which that doctor has to abide by. And we need to have legislators understand that we can't continue to play monopoly with our patients and have to have a different set of rules for every single patient that walks into our door. For example, remember the red bullet I showed you earlier that talked about the claims dispute resolution process at ACA. They contract that out to a third party called Maximus. It is a chance for physicians to take claim disputes and have a process for them to be heard. Maximus has actually done a good job with the claims that have been heard based on some changes we made to this third-party dispute resolution process a few years ago in the legislature. I think Representative Skidmore was instrumental in some of those changes, and we applaud that. And to tell you the truth, we thought we had fixed it. And I think, once again, under our glitches category, to begin with, Maximus has ruled successfully in favor of many physician groups that have taken these claims disputes. But then, of course, what has that done? Well, that prompted the health plan to opt out of participating in the dispute resolution process. They're claiming this opt-out ability is available because of past case law. And if they're allowed to opt out, this means it removes any ability for a physician to challenge underpayment. And this is a huge deal. I'll say this, when insurers are able to get away with underpayments to physicians, what that means is they're able to pocket those premium dollars without passing on those savings to the physicians providing the care. And that's a huge problem. And it's becoming more and more apparent now that the No Surprises Act passed in Congress in, I believe, 2021. And what that means is it's a bifurcated system. Any of our state regulated insurance products, those disputes have to be heard by Maximus, the state system, and any federally regulated health plans now go through the federal system. So your ERISA plans, for example. So who's winning in this scenario of a bifurcated system in which we have a state process in which the insurers are using a loophole to opt out? Once again, it's the insurers winning, it's not the patients. And talking about that in the whole monopoly game, another thing that we can look at Texas and see something that they've done that's been very helpful, especially now that we're talking about dispute resolution and there's two different processes for the state plans versus the federal plans. Texas has done something as simple as requiring on a ID card or any kind of electronic ID card that they actually say, is this a state regulated health plan or is this a federally regulated health plan? As you can see by this slide, though, there is a glitch in the Texas law, right? It just says anywhere on the card, they have to put either the TDI or DOI saying who is regulating the plan. As you can see from the slide on the right, it shows that sometimes they put it in little places and hardly, legible. So I think if we move forward in Florida, it should be all in the same like right-hand corner or left-hand corner and state clearly whether it's a federally regulated plan or a state plan. But this is going to become more and more important as we get more of the rules that are coming out of Congress, or excuse me, CMS, on how the No Surprises legislation is going to be enacted. I also want to talk a little bit about telehealth, because this is also kind of that whole issue of insurers behaving badly. This past session, we passed Senate Bill 312, and it really had more to do with prescribing, right? We all said we needed to be able to prescribe to our patients when they utilize telehealth. And that's a big win. So now 3, 4s, and 5s, you can prescribe a controlled substance. You can just prescribe a prescription. And Schedule 2, though, is still kind of regulated by just certain areas. It's psychiatric disorders, inpatient treatment at a hospital, patients receiving hospice services, and patients in nursing home facilities. So those you can prescribe a Schedule 2. Everyone else needs to come into the office if they're getting a Schedule 2. But in saying that, this is one of those examples of almost every physician I talk to, they say every new contract that's coming out with insurers, first of all, it's a take it or leave it contract. They're bringing it to the physician usually 30 days before it needs to be signed. So little time to really comb through and see what needs to be changed. And most of them are saying about a 60% reimbursement for telehealth. And so one of the things I have to tell legislators is the set costs haven't changed just because we moved the platform to online. A patient still has to call the office and set up an appointment. A patient then has to log on to the platform And usually a nurse has to go onto that platform and do many of the things that happen in your office. There's a medication conciliation. There's, how are you doing? What's your symptoms? What are you here for today? They take all that information, right? And then usually the doctor comes onto the platform and actually does the telehealth visit. But when that doctor's through, it still also requires a follow-up appointment to be scheduled. B, it usually calls for a prescription to have to be sent into the pharmacy. All of these things are still set costs. So we believe that there should be payment parity for these insurers and that physicians should be able to get reimbursed the same amount as if they would have done an inpatient visit. I think some of the pushback that I personally hear from insurers when I talk about this with legislators is that they think we want to do away with their exclusive providers. And I say no, in many cases, especially when you're talking about specialty care, you have a physician that will say many of the visits have to be done in person. But we found we could move 2 or 3 of those visits at certain key points in the care to telehealth. One of the examples we use is, say, orthopedic surgery. Before COVID, we never would have assumed that an orthopedic surgeon would ever be able to do anything via telehealth. But we realized really quick when COVID had kind of shut everything down, what visits of the continuum of care can be moved to telehealth. It's not when they're coming in to get looked at pre-surgery. It's not the surgery itself, right? All that's in person, but the post-surgical visit at the 3-day period in which you're looking at, okay, is there redness or inflammation around the incision site? How is your mobility? How's your physical therapy going? All those things that can be done via telehealth. And it's actually a big success for the patient, right? In many cases, a senior parent is having their loved one, say their daughter or son, take off work to have to take them back into the doctor's office. And if we can move that to telehealth, that would be great. But that also means we also need to be able to control their drug therapy, even if it's a Schedule II drug via telehealth. So that's something we'll continue to talk about and hopefully push legislators into realizing that we do need payment parity as it comes to telehealth. Back to the other policy recommendations when it comes to PBMs, I'm going to talk about 3 issues that we have continued to push before the Florida legislature, but has not seen much traction. We definitely have some legislative champions, both in the House and Senate, that have worked really hard, but we need more support. In many states that we see these types of bills being passed, it's because the Office of Insurance Regulation, or the insurance commissioner, has taken an active role. And we don't really have that here in Florida. Unfortunately, because of the storms that we just lived through recently in Florida, it takes up a lot of bandwidth at the Office of Insurance Regulations to concentrate on property insurance. But for what we do as physicians, we know that health insurance really impacts every single Floridian, just like property insurance does in a state like Florida. So the first one, we call it Make Charity Count. And this is called copay accumulators. And we have to be very careful because these are not discount cards. Discount cards are usually something you use if you're not going to use your insurance, right? You're going to get this little discount card and you're going to go and it's going to make your drug a certain price and it never goes to your insurance. Copay accumulators are a little different. It's something that PBMs are enacting in their contracts with the patient that says any third-party payments you receive and apply to your copays or out-of-payment costs will not count toward your out-of-pocket costs that you're responsible for. We think of this as probably drug manufacturers' assistance programs. Particularly, we all know that high deductible plans are the norm now. So it really hits patients hard that first month of a new plan year, right? They have a drug that's $1,200 a month. They have a $3,000 deductible. Probably for the first 2 or 3 months, they're going to have a lot of out-of-pocket needs. So the drug manufacturers, in many cases, give that patient these assistance dollars in order to help them meet the difference between the price of the drug and their out-of-pocket costs. In many cases, too, we need to point out this isn't people new to a drug. In many cases, this is patients that have been on a drug and have successfully been able to control their drug state. So we're not steering patients to one drug or another based on what assistance we're giving them. We're actually, in many cases, keeping a patient on a drug that is keeping them healthy. But instead, the PBMs are pocketing that charity care given by, say, the drug manufacturers and putting that toward profit instead of applying it to the patient's out-of-pocket costs. We've also heard examples of even third parties such as hospital foundations and or associations that might say for rejection of transplants. They might have a patient that's between jobs, doesn't have health insurance, but it would be more beneficial for them to help them meet that out-of-pocket cost of their high deductible versus them going off the drug and rejecting, say, a transplant. But instead, the insurer saying, no third-party payments made on behalf of the patients will apply. So this kind of sounds like a no-brainer, I think, but it's one that we've really found opposition by the insurers, and they tried to first confuse legislators between copay accumulators and discount cards, which we are not talking about discount cards. They continue to say this, if we did away with copay accumulator programs and we're steering patients to more expensive drugs, which we argue no, specialty drugs, usually there's not even a generic in many cases, much less steering, but this would just actually keep them on the drugs that keep them healthy. Also sticker shock. Most people are shocked to know that a patient pays their copays and deductibles on the highest list price of a drug. And think about that. You expect your insurer, your PBM, to be negotiating a lower price on a prescription drug so that you as a patient can benefit. But the reality is here in Florida, no, you're paying your copays and deductibles off the highest list price. And that's, if we made this one change, everybody's prescription out-of-pocket dollars would go down overnight. So we continue to push legislators to please require the insurer to base copays and deductibles off the negotiated price. The last one I'm going to talk about is non-medical switching. And this, I always define it, as you can see at the bottom, and that's the act of moving a patient from a drug that a patient is medically stable on to another drug, not because of any medical benefit, but solely on the price or profit for the PBM. And this is one of those things that at first everybody goes, no, this can't be happening. What? Are you serious? But the data is there, and we've all had it happen to our patients, right? They're on a drug, they're doing great, everybody is healthy. And then all of a sudden, mid-plan year, a patient, just because the PBM decides to change the tier of a drug or change the formulary, that patient can no longer have access to the drug that's keeping them healthy. So part of what we say about non-medical switching is there should be a requirement for an insurer, if they're going to change a formulary mid-year, that they notify the patient, and then the patient and the doctor can make a decision if that change would be detrimental to the patient's health or it would be acceptable, right? There are some changes that the doctor would say, you know what, let's try this. I think this would work. It's okay. But there's others that the doctor would say, no, that's in a category you can't take because, and what I hear a lot is say a pre-existing condition, or you've tried this previously, other issues like that. So we need to end what we call the practice of bait and switch. And that is our patients with drug needs during open enrollment, they usually shop around and they pick the plan that has their drug at the best price. Well, in Florida, we have nothing that prevents that same formulary list that they looked at during open enrollment to be changed at any point. And not only changed, but have financial impact on that patient. So we believe that if a patient's medically stable on a drug and there's a formulary change mid-plan when they don't have a chance to shop around and change insurance products, that patient should be able to stay on that drug at the same price until the end of the plan year. And then at the end of that plan year, they can shop around and try to find the insurance product that's best and has their drug at the best prices. So another one we would think is a no-brainer, has totally been a issue for us to get passed in the Florida legislature. I will say this, the state employees group health insurance, which legislators are on, just recently has gotten its first taste of a PBM. So in many cases, policymakers were kind of insulated from this practice by PBMs. And so I think in the next couple of years, we'll see more and more because it'll be happening to their loved ones. And some of that too, we're hearing that's kind of the impetus between the governor's executive order. When one of your loved ones needs a drug and there's the barriers there, artificial barriers in many cases that PBM or insurers put in the way, it makes you step back and say, yes, we need some patient protections around these issues. And none of this happens in a vacuum. So I just want to remind everyone, the election in November, we in the Senate, we know that Kathleen Passidomo will be the incoming Senate president. And we know Ben Albritton will be the Senate president from 2024, 2026. I will say Kathleen Pasadomo's father was a physician, so she's been very sensitive to physician issues and patient issues. So I think we probably have a real chance here during her 2 years as Senate president to see some movement on this issue, especially with the governor now coming in with his executive order and I think looking to push things forward. Also in the House, we know the incoming speaker is Paul Renner. We know Danny Perez is going to be speaker 2024, 2026. And then we know Sam Garrison is going to be speaker 2026 to 2028. I will say Paul Renner has always been a backer for physicians as well as patients. So I think we also have a good chance while he's speaker to move something forward. And same with Danny Perez, his wife is a pharmacist. So he does have to deal, you know, I always say your best sounding board is sometimes your spouse, right? So he hears it directly from his spouse about issues she has as a pharmacist trying to get patients you know, the prior authorization that they need in order to keep their patients on the drugs that keep them healthy. And same thing, Sam Garrison has been very open to say his daughter is a type 1 diabetic. And so they struggle routinely in keeping his daughter on the insulin that she needs. And so he has faced some of these different formulary changes and things like that. So I think we do have a favorable environment in the Florida House and Senate, at least for the next 2 years. I would say in the House for the next, you know, 6 years. But we might be pushed a little in the Senate to go ahead and get it done while Kathleen Pasadomo is there. I will say this, last year we had what was called an insurance summit, and we opened it up to all the different specialties to come and have kind of a sounding board on what are insurers doing that's really impacting their patients and their practices. I think it was very well received. I think physicians like to hear what's happening with other specialties outside their own. And then also many times say, oh my gosh, it's happening to me too. Oh, are you working on this legislatively? Let's get together and move forward. And let's bring all the voices to the table to explain how this impacts specifically my practice and my patients. And then another specialist will have another example of how it impacts their patients and their practice. So stay tuned. We will have an Insurance Summit 2023. And the idea is after we have one presenter from each of the groups that kind of talk about their specific issue, we also will have policy recommendations that then each group can take to the legislature to try to enact change. I will say we also have a PBM reform coalition that's been formed. It's a group of both patients and doctors who want to do more to push forward PBM reform. I'm happy to add anyone to that coalition list. Sorry about this. I know this is awful when you push through all these slides, but I wanted to go back to the first and show you my email or cell. You can text or email me your email address and just give me a little blurb if you have your email, if you want your cell or your mailing address, and I'll add you to that coalition. And especially during the session, you'll see most of the emails that go out, but we look at PBM legislation that's been filed. We also let you know when a bill is going to be heard in committee. We do one-stop click where you can just click and email your specific legislator on that committee with specific information of how that bill will be beneficial and or harmful to your patients in your practice. So let me know if anyone would like to join that. And I look forward to our team effort as we try to battle what we call the insurers. It's going to take all of us working together because they're quite a powerful group. But I think as long as we remember as physicians that we really are there advocating on behalf of our patients. And I tell legislators that all the time. Doctors are truly advocates for their patients. And when they take time out of their practice to come to Tallahassee or to meet with the legislator in the district, they really are doing it because they need to see change, because they need to help their patients. So I applaud y'all every day for not only what you do in your office and caring for patients, but being part of even presentations like this, because half of it is knowing the issues, knowing what we could ask legislators for, and then also just sticking with it until we see that outcome. So I'll turn it back over to you, Dr. Baca. Thank you so much for having me. I hope this hit on some of the issues that we hope the Florida legislature will move forward with.
Well, thank you so much for coming on. I have a couple examples of what you're talking about from the field. I have this one lady who could qualify for a government-assisted plan, but she's actually decided that it's cheaper for her. She can't afford her medications in the government-assisted plan, so she continues to not have any health insurance because it's cheaper for her to go to the pharmaceutical company directly and go under their indigent programs and get supplied medication, because if she qualifies for the health insurance, then she gets cut off from that. And then she has an accumulator program. So therefore she doesn't get credit for her deductible. And then 3 months into her insurance, it turns out that she has these huge deductibles, can no longer get her medication. So she actually finds it cheaper to actually not have health insurance to get her medications. But obviously the problem with that is, I mean, she has no hospitalization. She's foregoing a lot of other treatments or availability for other things, because the drug programs are actually so crazy that it's a problem. And I'll give you one more example. I have a patient who basically blue collar fellow. He's on a biologic, severe arthritis, basically cannot move. You know, his knees will be the size of grapefruits if he doesn't get his medication. So what happens is that he's also on a plan that has an accumulator program. And essentially what happens is that when the copay card is gone, what people understand is the copay card only has so much money on it. And once the assistance card from the insurance is gone, the pharmaceutical company is gone, then the insurance charges them full rate. So what this fella does is he literally can only take his medicine for 6 months out of the year. And then what I need to do is then I have to put him on a different product. And then we use that accumulated card up. And then January, you can get another copay card. And then, so once a year, we have to change his medications, even though he's stable. And it's terrible medicine. I mean, it actually costs the system a lot more money, because there are plenty of studies that show that there are increased doctor visits, increased costs with that. And if people go out of, and are flaring or not in good control with these changes, then it costs the system a lot more money. But this is the only avenue this fellow has in order to get his medication, because of the accumulated programs.
And that's such a sad example, right? And that's what I have to remind legislators every day, is that this is real policy decisions that are impacting patients every day. And healthcare isn't a free market, right? These poor patients don't have a choice. They only have the products that are out there and have been approved by the state. And if we don't put in legislation these patient protections, then there's nothing there to prevent the insurers from moving forward with this. I will say I challenge y'all all, when you're talking to legislators, first think of 3 sentences that describe yourself and what you do. And what I mean by that is, you might say, oh, I'm a rheumatologist, or oh, I'm a gastroenterologist. To tell you the truth, many times legislators are accountants or attorneys, and they have no idea what that really means. So for example, if you say I'm a rheumatologist, that means I'm a medical doctor that works in a field in which we use prescription drugs, new prescription drugs to control autoimmune diseases. And then in those 3 sentences, the last sentence should be the visual. Think back, not that long ago, you would visit a nursing home and you would see little old men or women in their wheelchairs with their hands drawn up, right? And they were no longer productive members of society because they couldn't even use their hands. Now these prescription drugs that we're able to use for our patients mean that people never get to that state. We no longer have that visual of patients in that wheelchair. But what that means is, if we can't get our patients on the drugs that work and keep them on, we'll be going back to days in which people are unable to work. So I gave one example about rheumatology, but please pick one specific to your specialty and think about it ahead of time. How would you describe to a legislator that might know nothing about healthcare, what you do and why you're there and why protecting your patients are important? And that visual, I think, is really, really important. And I think you just did a really good job of that with the story you told, right? How it really impacted that man and his ability to continue to work.
Dr. Rodriguez has a question. You're on mute.
So we have an internist in town. His father was an internist, his grandfather was an internist, and he's an internist. So his son went to college. On the first day he checked into the dorm, he died. The reason why that was is because he didn't have a glucose monitor, a continuous glucose monitor. So what I ask for is that everyone think about healthcare as a bucket. And that's really what it is. It's a bucket that we're all drawing out of. So what we have to encourage is every physician, every doctor, every nurse practitioner, PA, to remember that we have to prioritize what we have to do. If someone needs something that will save their lives, we have to do it. But we have to avoid unnecessary cost. We have to avoid doing an ultrasound on a patient to inject a knee because we're going to charge more. We need to send a patient for a stress test every year because we need to charge more. What I encourage everyone to do is to remember that healthcare is only one bucket. There's nothing else. We have nothing else. It's a bucket that we're all drawing out of. And it isn't about us and our income and what we're making. It's about people and their future and their healthcare. And if we want to get the best care for people when they need it, how they need it, and when they need it, we need to be conscious of that.
I totally agree. That probably should be another summit on the corporate practice of medicine, because I can show you reams and reams of data that people who are in private practice tend to order fewer things than people who are not. These corporations, once they buy practices, it's well known that their bills go up for the same services about 30%. And it's the same thing if the hospital owns a physician, except that they're billing under Part A Medicare, which is even higher. So, you know, we can provide the same services for fewer dollars if we can keep our doctors independent. But we're not able to keep our doctors independent because Medicare has literally not given physicians a raise in 20 years. We've had a 5% cost of living increase in 20 years, whereas the hospitals, hospice, and nursing homes have had a 60% increase in the same period of time. So any other questions? I wanted to ask one thing to you, Toni, just to make very clear to the audience, is on step therapy. I don't think that people understand the correlation between step therapy and PBMs and how that goes together.
Yeah, and you know, it's unique. I was just thinking about what Dr. Rodriguez was saying, and I will say this, and this kind of goes hand in hand with your question. We did do a survey of one of the specialties, and we said, okay, how many times do you request a step therapy override? And what the data showed is that for a newly diagnosed disease state, most of the time, the physician is able to look at the formulary that has been put in place by the PBM and say, okay, the first drug on this formulary is drug X. And guess what? I think it's okay. You can go on drug X. Let's see how you respond to that. So 80% of the time for a new disease state, they're able to go down that formulary route. But what the data showed is it's not usually a new disease state that there's a problem trying the first step in a therapy. It's for someone who has already been on a segment of care and needs to stay on that segment of care. And that's the problem. These formularies set by PBMs have nothing to do with the clinical components of what's good for a patient, but instead have to do with negotiated prices with drug manufacturers and rebates. I use that word lightly, rebates. In many cases, people will say kickbacks that drug manufacturers have to pay to a PBM in order to get on their preferred drug list or their formulary. So in many cases too, if it is a new disease state and there is a step therapy that's there, I'm hearing from physicians, there's just certain cases in which that first drug would never be beneficial to that patient, i.e. do they have a coexisting condition in which that first drug on that list could never be taken, say with somebody with kidney failure or kidney disease. So those are the scenarios in which a one-size-fits-all formulary could never work for all of your patients, and why physicians are cost conscious, right? Because they actually do want their patient to get on a drug and stay on a drug and be healthy, right? So if the cheapest drug is one that's going to work, they're actually going to put the patient on that drug because we know adherence is better when a patient can afford their drugs and to stay on their drugs. I will say this, about 6 years ago, we met with the insurance regulators in the state. And at the time, it was a different deputy commissioner, but he actually said to the physician that was with me, "Oh, doctor, we know you get kickbacks from writing a certain prescription of a name brand drug. So don't tell me that you always use the cheapest drug out there." And my doctor looked at him and said, "You know, that's illegal, right? There's no way I pick a drug based on the price. And in many cases, I don't even know what the price is because every single PBM has a different formulary. And really, I'm looking at the patient and their clinical medical needs and deciding what's best with that patient." So many of those things we have to remind legislators. I will say this, insurers and PBMs routinely try to make this issue sound so complicated to legislators, trying to talk them out of even trying to tackle anything dealing with PBMs. You know, in the past, we've had one omnibus bill that had all the three issues I talked to you about in one. And I think sometimes we realize maybe breaking them into separate bills helps people realize they're not as confusing or not as hard to tackle as they really think. And in fact, there's some little bites of the apple that could go a long way of protecting patients and or just transparency. I mean, look at the Texas law that just required PBMs to actually, for the first time ever, report data back to the state. I mean, small bite of the apple goes a long way. Even the issue of the insurance cards. Is this a federally regulated plan or is this a state regulated plan? Little bite goes a long way. And just even having a patient, you know, pay their copays and deductibles off the negotiated price and not the list price. Little bite goes a long way and would save every single person on this call and every patient in your office dollars when it comes to what they pay at the pharmacy. So we have to also continue to reassure legislators that this isn't so complicated that it can't be addressed, but that we can start taking little bites of the apple. And every year we do that, our patients are going to benefit.
I think patients are frustrated and you know, they want a path out of this. And you basically just outlined a very good path out of this problem that has to happen both locally and nationally. So really applaud your work. I mean, you've really, as I said, you're one of the good guys, you know, and trying to make things better for Floridians. Now, I'm going to ask you the question I asked Dr. Levin. Other than the fact that the FTC says that this is okay, how is the business model for PBM different than the business model for Enron?
You give me the hard one. No. Well, you know, ironically, I think that just goes all back to that free market, right? And unfortunately, PBMs try to say to legislators that their hands are tied, right? That they're dealing with these greedy drug manufacturers, and drug manufacturers actually control the price of drugs, and they routinely change the price of drugs, you know, in the middle of a plan year and yada, yada, yada. Well, ironically, the whole reason PBMs are there is to negotiate drug prices, right? And in those contracts, many cases are additional rebates a manufacturer has to pay if the price of the drug does go up. You know, there's some outliers, you know, you look at the inhalers, or no, it was, excuse me, the EpiPens where the price went up 300%, and even some insulin issues. But, you know, usually those were one bad apple that, you know, and had exclusivity on a drug and wasn't being a good corporate player in the healthcare market. Many would say like Enron, you wanted the example there. But in most cases, when you look at your drug manufacturers, they're negotiating in good faith with the PBM. They're paying their kickbacks or their rebates in order to get on that formulary. And the truth is, until insurers are held accountable for actually practicing medicine, which they are when they're putting barriers to prescription drugs or even procedures or devices, what they're doing is practicing medicine. And we need all physicians to understand, as long as insurers are practicing medicine, whether it's the PBM or the insurer, then it's just the same as scope of practice issues that we fight as well. You know, we don't want nurse practitioners or PAs to be able to say they're a doctor and treat your patients just like they're a doctor. And same thing, we don't want insurers to be dictating medicine to the physician. And I think what kind of goes silent sometimes is, I think you said it earlier, Dr. Boga, when you say it's just poor quality of medicine. We would never do that, but we're having to do that because it's what the system that we're dealt with. And so that is why patient protections need to actually be in legislation, because that's something you hear too. Why do we need to address this legislatively, Tony? Can't doctors just negotiate these issues in their contracts with insurers? And I will repeat again, as long as it's a high stake, take it or leave it contract that you get once a year, and usually, 30 to 20 days before it has to be signed, and you're not allowed to change anything in that contract or else you're going to be dropped out of network, it means you have no control. No control. So hopefully you are realizing that negotiating contracts with insurers are just as important as what you do in your exam rooms, because that's one way we can try to tackle this. But the truth is insurers are not behaving nicely. They're not playing fairly, and you are forced into contracts. That means you are taking, say, the 60% for telehealth visits, or you are having to do all these step therapies, prior auths, and some of the other things. So, and we haven't even talked about white bagging and brown bagging. And it's one of the slides I forgot to add. We're seeing insurers, brown bagging is where they mail the drug, usually an injectable, to the patient and tell the patient to take it to the doctor's office and have the doctor infuse that drug or inject that drug. They're doing this because they want to use their own exclusive specialty pharmacy to mail that prescription. But we all know physicians can't take on that liability of a drug that they have no idea of the chain of custody. So right there, we think brown bagging should be forbidden, and a physician should never have to inject or infuse a drug that they have no idea where that drug comes from. Or even sometimes think of oncology. Sometimes they use oral prescriptions. That same thing, if it was mailed directly to the patient's office, that doctor has no accountability of that drug. And then white bagging is where a pharmacy or an insurer PBM, they take a prescription drug and require the physician to use a specialty pharmacy picked by the PBM and the insurer. Problematic there's two things. Many times doctors like to almost like interview a specialty pharmacy, right? And ask many questions like, okay, what's your criteria for delivery of drugs? How are they stored? What if the office is closed when you get there? You're just going to leave it on my front doorstep? Are you going to retain possession of that until you can actually give it to me so I can put it in the right temperature? There's a whole bunch of questions, right? But now insurers are dictating you use their specialty pharmacy. Another issue, though, is many physicians that do infusions, injections, or even oral drugs, they can buy in bulk and then distribute that drug to the patient that day as needed at a much cheaper price. Unfortunately, some of the hospitals use 340B pricing and get the drug at a cheaper price, and then they write up that drug for like 10, I don't know, I've heard huge amounts. Yeah, huge amounts. And that's kind of the bad apple, but the good apple are these physicians that are actually saving the system, but they're also being forced to use a specialty pharmacy picked by the insurer, not by the doctor. So those are other things. We were hoping the Board of Pharmacy would act on that, but they have not. But moving forward, we hope to address white bagging and brown bagging too, because in your practice, you have the liability. So if you're going to take on that med mal that that you could be sued for, then you should also have control of where the drugs that you use in your practice come from, especially when you in many cases would be a cheaper alternative to be the supplier of that drug versus the specialty pharmacy picked by the insurer, just because of the same thing, probably rebates or kickbacks they're receiving from a specialty pharmacy. We need to do what's right for the patient, and definitely is not white bagging and brown bagging.
All right. Well, I really appreciate you coming today. It's very informative. I'm sure that everybody learned quite a bit, and I always learn lots of stuff every time I talk to you. So I appreciate it so much, and good night, everybody. So next week, we're going to have our last talk. Now, I'm going to talk about tricks and how to reduce your prices. So we'll talk about the discount parts. We'll talk about whether or not you're able to access other programs that might lower your healthcare costs, and how to avoid a lot of pitfalls. Just as Toni said, I mean, I recently had a prescription at the pharmacy, went $70. I went on one of the discount cards, and I got it for $12. And my insured price was way more than my no insurance price. So there are ways of getting around some of this stuff, not all of it, but we can do our best we can. We always try to guide our patients to do that. So thank you again. Good night.
Thanks, Toni. Good to see you. Thank you, Dr. Baca. Good night, everyone.
Good night.
Thank you, everyone.